Hi guys, how are you all doing? I hope everybody can hear me, and I hope your week's been okay. Just let me know on the Q&A or on the live chat whether or not there are issues with the sound and I can make some adjustments. Welcome to today's webinar. It's been a long old week, even though we probably haven't done that much. And today we're going to talk about, I suppose, the start of the sequence in terms of the endodontic treatment sequence that we carry out, and we're going to talk about a variety of different things in relation to thank you for letting me know that you're hearing me fine, in relation to the restorability and the prognosis of teeth. And we'll go through some cases. I have quite a lot of polls, live polls, that are put into today's webinar as well, different cases, different images that you can look at. Some of them will work and some of them won't. It's dependent upon which device you're watching the webinar on. But again, you can let me know and we can always go through these images afterwards, or we can go through them in a case-based discussion format, maybe at a later date. So I suppose one of the places to start is to consider what the aims of today's webinar are. And I think we can be kind of PC ploddish, as it were, about our assessment of restorability and our understanding of prognosis. And I think all of us face those difficulties. And in keeping with last week's kind of idea of, keeping it as simple as possible and keeping a set of kind of small rules, or maybe a rule of 3 or 4 or little things to remember, for me, I kind of look at restorability in terms of it being a crime scene. So what we find when we get there for the first time, what does the tooth look like? What we do when we get there. So for example, specifically related to, do we remove caries? Do we remove restorations? How do we do it? What are the techniques that we use? Do we create any errors when we're assessing restorability? And I always think of the example, and this happens to me all the time, and I'm sure you as well, when you're trying to remove a crown, even if you're looking under magnification, and you end up taking a little cervical gouge out of the prep, so that when you get the restoration off, you look and you think, yeah, it's restorable, but now I've got this really awkward little area that I'm going to need to restore or incorporate into my preparation. So that, for example, is often an error that we introduce into the process. And then what we miss when we're there as well. So we're looking and looking and looking. And sometimes I think we look so hard that we don't kind of know what we're looking at all. And it's important, I think, that we set out from the beginning what it is that we're trying to achieve. And that importantly, and I'll talk about this at the very end of today, we communicate that effectively to our patient, because that really, really is an important part of it. In keeping as well with last week, I suppose I'll start by talking about the definitions of restorability and prognosis. And restorability is a difficult one because you're never going to find an English definition that will be applicable to dentistry. But I found this, and it says it's fit for restoring or reclaiming. And I like the word reclaiming here because essentially that's what we're trying to do here. We're trying to salvage a situation and bring that tooth back from the brink, as it were, depending upon the degree of the restoration, depending upon the patient expectations, depending upon the strategic importance of that tooth in an overall sense. Prognosis is a slightly different one, and if you look at the definitions that are up here, a lot of them aren't particularly relevant to us, but I like the forecast of the likely outcome of a situation. And if you look at the Greek origin of the word prognosis, and I remember asking a group of students this before, and one of them gave me this answer, and they said that the Greek origin would suggest that what it means is that it's our ability to foreknow, so to know in advance whether or not what we're going to do will work. Now, I get that that's a very multifaceted thing, and we're trying to simplify that down to one statement or one explanation for a patient. But if you keep that in mind, I think that's really of enormous value. Can you foreknow what will happen if you do a variety of different things? And of course, there are specific practical steps to take during that process that will simplify the answer to the question and will make it easier for us to communicate that back to our patients then as a result, because actually that's probably a big part of it. I think that when you look in particular at the GDC outcomes, often the dental outcomes are very heavily focused towards, are we improving our skills, are we improving our knowledge, and kind of leaning away from, is this practice management or communication or consent? But this really is an important part of the consent process. as such, and we all know this from going to various indemnity lectures, when a patient sits in the chair and when rubber dam is on and when you're doing the treatment, that consent, of course, it's an ongoing process, but you've gained consent at that point. But these conversations that we have with patients about restorability, about prognosis, about cracked teeth, about teeth with subgingival margins, these are the conversations that really, really matter to a patient. And later I'll reference a paper from 1957, and it is remarkable how aptly they have defined that process and how little it has changed in the intervening, say, 60 or 70 years. If we look in terms of what a patient believes about this, all these questions tend to come up very, very regularly. So is it worth it to do this treatment? Patients will say, it's an awful lot of money I'm investing, it's an awful lot of time, I'm struggling to get the time off work. And that's going to become massively common, I think, once this crisis passes. And again, I was looking at a thing on Dental Town earlier about how will dentistry change at the end of this. Nobody knows the answers to those questions. I think dentistry has changed enormously over the last few weeks, and hopefully it will change back to a large degree as well over the following few weeks. But what will change is that people's time, I think, will become more precious. Because number one, they will have faced through a period where they will have reflected on, I suppose, their whole lives in general. And number two, work-wise, we're all going to be very heavily committed because there's going to be an influx of things to do when this ends. And so patients will ask that question. They'll ask, is it worth it? Not just from a financial viewpoint, which will be relevant, but also from a time viewpoint. And if it's going to take lots and lots of visits and lots of different interventions endodontically, periodontally, and restoratively to save a tooth, maybe that's not worth it. And then patients will ask, will it work? Is this treatment actually going to work? And I think that is important. From a patient point of view, it's probably the most important question. One of the other ones that they'll always ask is, how long is it going to last? And I think part of today is to talk about not giving definitive answers to these questions, because I think in dentistry, we're engineering minded, and we will often say, oh, maybe 7 to 10 years. But 7 to 10 years based on what? Based on some academic evidence or based on the specifics of that patient's mouth? So I think I would move away from that and change it to having a frank and honest discussion with the patient based on a set of rules or principles or templates that you've established in your mind in relation to restorability and prognosis. And so there are, of course, red lines. And what I find funny about these red lines is that everybody's red lines are different. And I often find myself thinking, I wonder what my own red lines are, and would I change them? Or do I change them? Am I consistent? That's one of the questions I often ask myself. And I'm going to pop up a little poll now, and I'm going to get you to have a look at this. And you let me know what you think in terms of your own red lines. These are things that I have picked and that I have looked at. And don't worry if you can't vote or if it hasn't popped up on the screen. Some of them will and some of them won't. For the people who can't see it, there are things like crestal level, remaining dentine, patient wishes. Is that a red line? Is that something that affects our ability to make decisions with our patients? Financial, difficulty of overall treatment. And if you've got any other ones to add, you can of course do that. And as I said, don't worry, some of them you will see and some of them you won't. When I look at what you're saying in relation to that, a lot of people are talking about the dental factors in relation to our red lines. And I think that's probably a practical place to start, because if you make it too much about financial considerations, too much about patient wishes, too much about the overall position of this tooth, I mean strategically importance-wise in this dentition, I think sometimes that can take away from the kind of difficult decisions we have to make in relation to, you know, amount of remaining dentine, crestal level of the restoration. And I find it funny because we talk a lot, and I've been examining now for a good number of years, and that this definition of a ferrule comes up so often. And it's so complex and convoluted, and I don't think in all the times I've asked that question that I've ever got the same answer, and I don't know if I know the answer myself either. But what we mean essentially is the amount of tooth that's above the gum. And I'm saying this on the right-hand side of this as you look at it, because this is really how we should be communicating this to our patient. We look at a subgingival margin and we say, and this is in the context of a posterior tooth, can I get a matrix band on? And we look at crestal level and we think, if we're thinking and we're sitting on the fence and saying, is this appropriate? Should I be restoring it? Really, if you've got a margin at crestal level, there would need to be a very, very, very specific and relevant, maybe medical reason as to why you were keeping that tooth in. I think you would have to ask yourself, not whether or not you can get a restoration in, not whether or not you can adapt it well, but longer term, what is the outcome of that restoration going to be? And is it going to be satisfactory in terms of cleansability? Is it going to be satisfactory in terms of the patient being able to maintain it? Is it going to be satisfactory in terms of encroachment on the biologic width? And I know we don't use that term anymore, because all of those things are going to have an impact on the outcome. And the outcome is not just what it looks like on a radiograph. The outcome may be that a patient is coming back to you persistently and saying, look, this is just really sensitive in that area, really tender, bleeds when I'm brushing. And that's not something that we necessarily want to get ourselves involved in, because I think often we know that we're going to get there before we ever make that decision. Someone has asked for a definition of what a ferrule is. And I think it's interesting because it comes from this idea of kind of encasing a barrel basically with metalwork in order to maintain it together. But for me in dentistry, the ferrule is really the amount of circumferential dentine that you have in order to resist these lateral forces that you will have put on a tooth. So if you think of an anterior tooth and you think of it numerically, you've got to have 1 to 1.5 millimeters of tooth tissue circumferentially. Secondly, you need to consider where those forces are acting on the tooth. So for an anterior tooth, if you have no buccal or palatal dentine, and if you consider a post to be a comparison to a fence post in the ground, if you don't have anything for your restoration to grip onto essentially circumferentially, cervically around the tooth, you're going to end up with that fence post rocking backwards and forwards, and it's going to just pop out of the ground or pop out of the tooth. So for me, I would always look at a ferrule in terms of what I've got left for my restorative material, be it direct or indirect, to grip onto. And if you have an equigingival restorative margin, unless you have a very deep sulcus or unless you're thinking about doing some maybe surgical crown lengthening, it's going to be very, very difficult for you to do that. But this is an interesting paper, and this paper gets quoted over and over and over again, certainly in endodontics, but probably in a general restorative sense as well. And I'm going to ask you to take a look at another poll here, which is essentially asking you, what are the situations that you do take out your restorations in? Okay. Do you always take out indirect restorations? Do you always take out direct restorations? And if you ask yourselves why and when you do that. So I'm going to give you a second to have a look at this. And again, some of you won't see this, but don't worry too much if you can't see the poll. Okay, so lots of answers coming in saying that people take out direct restorations, and some people saying not always with indirect restorations, but always with direct restorations. So that kind of theme tends to go quite commonly through dentistry, because a lot of people will say, yeah, look, I'll always take out a direct restoration, but not necessarily an indirect restoration. It's interesting. I think part of that is to do with, I think, simplicity. Because the simplicity of taking out a direct restoration, it's great because you take out that restoration, you can assess everything. If you look at the results from this paper, they found that when you looked at a tooth clinically and radiographically, and I always say this, and when I read this paper, I always question why I say it, but I always say if a tooth looks clinically and radiographically sound, you don't necessarily need to take out the restoration. Paul Abbott in his paper found that you miss cracks 60% of the time. You miss caries 86% of the time. You miss marginal breakdown 99% of the time. So that is an enormous amount of error essentially that we're introducing in. And that there's only a 56% chance overall that you're going to identify the original causative factors for the pulpal or periapical disease. Now for me, does that mean, even in the context of this paper, that I will take out every single restoration, direct or indirect, when I'm treating teeth? No. But if we take a look at an image here, we've got some heavily broken down teeth, but look at image A, and you can see in image A, you have got large temporary restorations. 2 of them are conjoined. you can't assess those teeth essentially without removing restorative material from them. And if we look at tooth 2.6 after it's been removed, should we remove the restoration here? Is it a restorable tooth now that we have removed the restoration? And some of you again will see this poll. Is it an unrestorable tooth? And this is a case that I actually treated myself. It's about 10 years ago now. And I look at it and I think, it's interesting because I know the treatment plan here, and I look at that tooth now, and my gut feeling, and 82% of you, 83% of you are saying that, and you're agreeing with me, thankfully, you're saying that you think this tooth is restorable. And actually that tooth was scheduled for extraction. And part of that was because it was done in a hospital setting when I was in the Eastman. And I think sometimes the criteria there, and it's not a criticism of the criteria in hospitals versus in practice, but I think sometimes they're a little bit less real world than what we face in practice. But the feeling was that the tooth was unrestorable because there wasn't enough residual dentine left for a final restoration. And I'm not going to give you too many hints in terms of that because I think the final restoration here is completely a matter of choice. Is the tooth restorable in its raw form? Does it have, number one, enough dentine supragingivally? Yeah, I think it does. Does it have margins that are visible and that I can put a matrix band around? For me, I think it does. Is there some caries there that needs to be excavated? Yes, but I think I could predictably restore that tooth. So then, of course, the next question then you would consider is, what would you restore that tooth with? How would you restore it after endodontic treatment? Is it a direct restoration? Is it an indirect restoration? And this will hopefully flash up on your screen. And these are often the difficult decisions that we make. And they're the difficult decisions we make because our patients don't necessarily want to have an indirect restoration put on their tooth immediately after endodontic treatment. And then that leaves us in a position whereby we're saying to people, should they do it immediately? Or should they do it 6 months after treatment? And does that affect the prognosis? And I think that's a difficult decision to make sometimes. For me, I think cuspal coverage is important in terms of the prognosis of a tooth once it's had endodontic treatment, but that cuspal coverage does not always need to be indirect cuspal coverage. And I think that is important. We shouldn't be applying these specific blanket rules in terms of papers that tell us you have to have cuspal coverage on a posterior tooth, in terms of whether or not the marginal ridges are breached and whether or not you put cuspal coverage on top. And I'll show you a specific case in relation to that later. One of the other things we need to consider specifically in relation to this tooth, and I thought this was a good example because if I look at this, these are the type of teeth that we do treat. And if we consider what this tooth looks like after it's been prepared, either for a direct cuspal coverage restoration or for an indirect cuspal coverage restoration, we need to consider whether or not this tooth actually needs a post. And if you look at it, sometimes when we look at a tooth and we think, does this tooth need a post? You look at it in the first instance and you kind of say, well, in that form, probably not, because I've got a palatal piece of dentine. And if I've got a palatal piece of dentine, do I need to put a post in? What extra things am I gaining from having a post in this tooth? But if you consider what this tooth might look like after it's been prepared for an indirect or even a direct cuspal coverage restoration, do you need that post to retain the restoration? And by restoration, I mean core, and thereby potentially improve the prognosis of that tooth. And that's an interesting kind of choice of words, because I would never ordinarily say that a post improves the prognosis of a tooth, because historically when people describe posts as reinforcing roots, I always found that interesting, because that patently just is not true, that it will reinforce a tooth. It's just not possible. And looking at it, to say that it would improve the prognosis of the tooth, you'd really have to question that, because it's never going to improve the prognosis taking away dentine. But equally, in a practical sense, for you guys working day to day in practice, if that patient is coming back and they lose their core and it's sitting within a crown, or they keep fracturing a restoration or keep losing a restoration, and you think maybe a post will help to retain this, then that of course influences the overall prognosis in a situation like this. And then we need to ask ourselves whether or not we should be taking out restorations in every case. And I often use the example, if you've put a crown on yourself, say 3 months previously, or you've done a very well adapted composite restoration 3 months previously. Personally, I think it would be crazy to go back in and take that restoration out and destroy it and search for things that you will have searched for relatively recently. But equally, it's often not as simple as that, because often the situation is more that you look at a restoration clinically and radiographically that's been in place for many years, and you wonder, should I take this out? Is there a marginal breakdown underneath it? Is there caries? And I still have to say that my feeling is, if there are no signs visibly clinically or radiographically of any pathosis, any deficient margins, any caries, I think it does seem destructive to remove that restoration. And that's just a generalization, I understand that. And it doesn't apply to every single case. But I think you've got to apply some rules in terms of your initial approach to these cases. I'm not saying that your approach won't change. This is fluid. And as you go through it, of course, there will be times that you access through, for example, a cast restoration, and you're looking with loupes or a microscope or just with your eyes, and you say, hang on a second, there's something not quite right at this distal palatal aspect of this tooth. Or very occasionally you will see something like saliva draining up underneath the margin of the restoration. And sometimes it does take doing the access before you realize that. And so for me, applying a blanket, well, I take every restoration off. Academically, it makes sense. Of course it does. If you look at Paul Abbott's paper, it's indisputable. You can't argue with the evidence. If he's saying we're missing marginal breakdown 99.6% of the time, you would say, well, bloody hell, I need to get this done for every case then. But that in a way is not necessarily what we encounter every day. You know, and if you're talking about those number of cases versus the number of teeth you will treat in your career, you can see there are vast, vast differences there. In terms of removing the restoration and assessing restorability, I think it's important that that is done quickly. Anytime I talk about endodontic treatment, I talk about efficiency and I talk about speed. And I do that not because it's better to do it quickly from our point of view as practitioners, but from a patient's point of view, it's better as well. Okay. And I think that is important. I think speed and comfort, and when I say retrievability, I mean that you can put it back together again. When I consent a patient, I will often say to them, you know, we could take this tooth apart, but we might not be able to put everything back together again. But at the very least, you're going to leave this surgery with something resembling a tooth. And the simplicity of that, I think, is important to patients. Because if we say, well, we could take it apart and it might be unrestorable, that means nothing in essence. You know, it's just confusing because they probably don't know what restorability means in the context of a tooth. What they care about is, if you take it all apart, will you give them something that will look relatively similar? The speed part of it is important because this often takes place at the beginning of the treatment. And if I was a patient, I would look at this and I would say, this part is kind of pointless. I just want my root canal done. Can we speed up through it? So if that's their feeling on it, it should be our feeling on it too. And as much as we like to dress it up and say, you know, this is a very important part of the treatment, of course it is, but it's a means to an end. So it should be done quickly. In terms of comfort, I like multiple tooth isolation. I like it because it means that the patient is comfortable. They're not getting debris in their mouth. I like it because they're not going to inhale or swallow anything, especially if I'm taking a post out. And I like it because it means that I can then go on and do my endodontic pre-treatment and build the tooth up very quickly and re-access it and do my first stage root canal treatment. So that when I finish and the rubber dam comes off, it's off and the first part is done. As opposed to the dam going on and off and on and off, and it makes it quite complex for the patient and for you yourself as well. In terms of burr choice, you've got to have the correct burr. You've got to have a diamond to go through porcelain. You've got to have lots of diamonds to go through some of the newer ceramics. And don't be afraid to use lots of burrs. You know, there's nothing worse than using a blunt burr trying to go through a restoration and you're leaning on it and you can guarantee that you are gouging the cervical dentine with that. And to go through metalwork, I use a cross-cut tungsten carbide burr and it will cut through it unbelievably quickly. I tend to use shorter burrs when I'm doing my initial, and I'm using the example of a crown because obviously it's more complex than a direct restoration. I tend to use shorter burrs, but once I've removed the restoration and I'm accessing into pulp chamber level and pulp floor level, I will move on to something longer. Maybe a kind of a 630 diamond, something tapered, something that I can disengage from the handpiece slightly, and then that will allow me to get more visibility. And interestingly, I would never advocate disengaging a burr from a high speed if you didn't have rubber dam on. So again, it's another added advantage that I hadn't even thought of myself. But I just like the fact that the rubber dam is on, because it means I am then working, I am doing endodontic treatment, I think I'm doing it, and the patient thinks I'm doing it. And when the dam comes off, we've at least moved it on a stage, albeit in some cases the stage being, I can't save this tooth and you're going to have to consider extraction. And these are just some photos taken down the scope, primarily to show a few different things, to show the sectional matrix in place, to show a tooth with the restoration removed from it. And I like using SDR. I will talk about this in the obturation and restoration seminar in a few weeks' time. I love using it because it's so quick, and there is some evidence, as much evidence as there is about any other kind of a flowable type composite, but it seems to perform well. 2 years is an incredibly short period of time to be assessing the outcome of composite restorations. But if it's comparable to what else is on the market, I think it's satisfactory. One of the things I would want you to look at up here is that the irregularities of those cavities are they're very difficult to fill, I think, personally, with glass ionomer or even with a standard composite. The reason being that if you don't have something that flows quite well, you'll often end up with some voids under the restoration, and voids are the enemy of root canal treatment intraoperatively, because you'll get leakage of your hypochlorite or you get leakage of saliva in between appointments, and postoperatively, obviously, in terms of coronal leakage as well. And they're very, very important, because that ultimately may be your reason for failure. But yeah, I like the fact that it's done under rubber dam as well. That case is taken start to finish. That's post-operative. You can see the GP. But that case is taken start to finish, single visit, dismantle the restoration, temporize with glass ionomer, do my root canal treatment, rubber dam stays on, and then 2 sectional matrices. You can see I've chosen to only use the ring at the mesial aspect, because sometimes it's just logistically impossible to get a rubber dam clamp 2 palladent rings on, and it can be really, really awkward. But I have to say, I do like the use of that sectional matrix system. And it's something I always wonder about. Are these matrix systems that you use yourselves? And I'll pop a poll up just to see, as a rough indication as to how many people use them. I like them, but I have to say there are faults with them as well. And we're getting some answers. Yeah, a majority of people saying that they do use sectional matrix systems. One of the things I find really annoying about them, actually, is I find that sometimes in a very badly broken down tooth, when I've got that matrix system on, it's not as useful as using a continuous matrix. And continuous matrices get a lot of bad press in terms of interproximal adaptation, and also in terms of the fact that they create a stress within the restoration. But sometimes I find if you're missing a buccal or a lingual wall or buccal or palatal wall, the sectional matrix system doesn't tend to sit in the correct position. And sometimes for my endodontic pre-treatment, I will use something like an auto matrix. And I wouldn't be afraid as well, when you are using an auto matrix, you can actually use the palladent little clamp, and it can adapt the auto matrix nicely in terms of the contact. So it's always, I think, possible to kind of just play around with these things, and to kind of, you know, look at them and kind of say, well, I don't have to use every single piece of that system, because maybe not every single piece of that system suits me. And I think that is, it's an important thing, both in terms of restorability and prognosis, i.e. you've got to adapt according to the situation that you're looking at, and also in terms specifically of the techniques that we use when we're doing it. And so from there, you've got to come to the verdict, and you've got to say, okay, is this tooth a restorable tooth? And before I talk about any of this, and this really, I suppose, is the important part, isn't it? Remember, your decisions and our practice is littered with bias. There's tons of evidence on this, tons of evidence that says we're harsh critics of other people's cases and more favorable in terms of our own. And this is all in endo now. It tells us that dependent on level of experience, that can completely bias how we make decisions, not in a good way. And it tells us as well that although we learn loads, and you guys are engaged here in a webinar and we're learning about restorability and evidence and academic papers, despite all of the CPD that we do over the course of our careers, sometimes we limit our decision making to what they describe, Fist and Wright, and these are a series of papers where we limit our decision making to a series of applying a series of heuristic principles. So essentially, did it work before? Did it work in my hands? I'm going to try and do that again. And you know what? Previously, especially when I was studying, I used to think, oh, I don't know if that's a good idea. How is that based on evidence? But that is based on evidence. Because if you take it in the context of the fact that everybody is committed to doing a large amount of CPD, they're fulfilling the evidential part of it anyway. And then we make our decisions. And what's wrong with saying, well, actually, I've done that before and it worked well. Isn't that how we're kind of tweaking and perfecting our practice as we go through it? But it's interesting. Don't always think that although we have our set of red lines, although we know Abbott's paper, although we know a variety of different things, sometimes it comes down to us looking back and saying, actually, I've done that before and I'm going to try and do something like that again. The other way to do it for me is a bit more robotic. And these are tooth restorability indices. And then I always wonder whether or not people actually use these. If you look at the Tooth Restorability Index done by Alva MacDonald and Derek Setchell from the Eastman, it's quite complicated. It also has small numbers because there were only 20 patients included in this, and they looked at the strategic importance of remaining denty. And they essentially divided a tooth into 6 pieces, and every part was given a score of 3. And then the maximum score was obviously 18, and there was a cutoff point below or above which you couldn't be restoring a tooth. And that for me is kind of all it is essentially kicking the can down the road, because what it's saying is that you can get a maximum score, but you still need to decide what score you're giving each sextant. And that can be difficult because it's not like looking at a probe, you know, and doing a BPE. It's nothing as obvious as that. It's still you looking and trying to make a decision based on what's there. And then you've got a more recent Tooth Restorability Index, or they've called it a Dental Practicality Index, done by Andrew Dawood and Shannon Patel in London. And they divide it into different aspects. And they talk about scores of 0, 1, 2, and then 6, bizarrely. 0 being a tooth where, okay, there's no intervention required, and you just don't need to, because it's minimally affected by anything, up to 6, which is saying you shouldn't be treating this tooth at all. And what they look at, I think, is they look at the structural integrity of the tooth, which is important. They look at the periodontal treatment need, and that's important as well. And they look at the endodontic treatment need. And they also importantly look at the context. So they look at the bigger picture. Where does that tooth sit in that patient's mouth, locally and generally? And that is really, really important, because when we ask in exams, you know, what do you think is the prognosis here? And I will use this a lot with patients. When they will ask, you know, will it work and how long is it going to last? I will always bring it back to saying, well, actually, I don't know the answers to these questions, but what I do know is I know that there's an endodontic, a periodontal, and a restorative status of a tooth. And I've asked you guys, do you use these indices? And if not, why not? And these were the reasons I came up with myself. They're too complex, I can't remember them, and they're not practical. And it's heavily weighted. Your answers are heavily weighted in favor of saying they're just not practical, or you can't remember them. And they are the exact same reasons for me. If I go back into practice, whenever practice opens up again, and I say to myself, you know, I must use the Dental Practicality Index, I'll have forgotten it, you know. And I put these slides up today to say, take what you need to out of these. You don't necessarily need to say, well, I'll use the Dental Practicality Index, but you do need to remember, well, hang on a sec, I got to look at this. And this is what you're doing subconsciously in practice every day anyway. But sometimes I think it loses some of the bridge when we're communicating it to the patient. And I always say this to our students, what we do badly, I think, in terms of explaining to patients on new patient clinics or you guys in your practices, we can describe radiographs well, and we can say this is what's going on and this is what we think needs to be done, but we struggle then to transfer that into being able to say to them whether or not it will work, because we feel, well, I don't want to give you an answer, I don't want to sway you one way or another. But if you take some of the subjectivity out of it and you say, well, okay, there's a perio, an endo, and a restorative question to look at here, and there's the context of you as a person and as a patient to look at, I think that's useful. And rather than going away and reading these papers and calculating scores and adding up numbers, take those 4 things out of it and say to a patient, when they question you and say, I don't know, it's evidence-based. I'm not saying that's how the evidence is specifically described, but there's definitely something of value in that area. And it's interesting, can't remember them and not practical, that they're equal. That's what you're saying. And I would totally agree with that myself. And then there are other factors to consider as well. Looking at this tooth, this is an interesting one because there was a decision, and you know, you're trying to decide what's best for this patient. Is it apical surgery? Is it non-surgical root canal treatment? And there are other factors to consider here. And when I looked at this, my immediate reaction was I wanted to do apical surgery. And you're very much disagreeing with me based on the poll that I've sent out. And I looked at it and I thought, I didn't do apical surgery here. I did non-surgical retreatment, and the tooth healed well. I don't have the post-operative radiograph up here, but part of what swayed me in terms of apical surgery was, oh, look, is it a well-adapted restoration? And I'm back again to, are the clinical and radiographic margins satisfactory? And they're not, clearly. Really what was swaying me here when I looked at it was, wow, that's a really easy tooth to put a retro filling in and to clean, because it looks as though it might have had some surgery before. It's certainly a blunted apex, and you're massively in favor of non-surgical root canal retreatment here. You've got 75, 25%. Neither of those are wrong. We treat teeth surgically that have margins of restorations that are not perfect radiographically. This crown had never dislodged, so that was one of the other factors to consider. The patient had a low lip line. That was one of the other factors to consider. They were very much easy about which approach we were going to take. But looking at it, I worried about my ability to take that post out because it's very well adapted, but they're always the ones that seem to come out relatively easily. Equally, I felt non-surgically, if we encountered a mishap in taking the post out, which is very, very, very rare, according again to Paul Abbott, would it be easy to replace? And yeah, it would. Unrestored canine, minimally restored central, obviously it's got a restoration that needs to be corrected. But you look at that and you think, these are all the other factors that you're taking into consideration. And again, when I look back and I say to myself, how will I make this decision? In a way, you go back to Dawood and Patel and you say, endodontically, where's the difficulty here? Periodontally, yeah, it looks okay. You know, definitely some mild horizontal bone loss. I can't remember how old the patient was. But crown root ratio is not great. It's not great in terms of length. If I cut another couple of millimeters off that tooth, it's probably going to become a little bit more mobile. Restoratively, what does it look like? I don't know. But there's a question mark, certainly, over the distal margin of that restoration. And where you see something like that, and you see that kind of circumferential radiolucency, you always worry that there's going to be caries there. Always worry, and that you're going to take that tooth apart and you're going to say to a patient who has had a restoration in there for 30 years, I'm sorry, but I'm not going to be in a position to save this tooth. So there are a lot of other factors to consider, definitely. And then I suppose one of the most difficult situations we face, and I don't think I'll ever find an answer to this, is cracked teeth. Because we try to understand, and this is a prognosis thing. These teeth are restorable. Because I look at this photograph that I've taken online, and these are the classic situations that we face ourselves in. You take out a restoration and it looks like this. And the patient may or may not have had symptoms, and I'll talk about that in a second. But you look at this and you say to yourself, is it restorable? In terms of crestal margin, in terms of amount of residual dentine, in terms of encroachment on the biologic width, it's restorable. There's no question. 100% of us will agree with that. It's got a ton of tooth tissue remaining. But what is the prognosis of a tooth that has a crack in it? And that's a question that's very, very difficult to answer. I think part of the problem with that is that we don't know where that crack extends to. And when we don't know where it extends to, we don't know how to describe it. We don't know how to explain it to a patient. And of course, if we don't know how to explain it to a patient, how are they going to be able to make a decision, and how are we going to be able to make a decision? And the AAE talk about a number of different presentations of cracks in teeth. I had to check this again this morning to see how many they actually have. And I've asked you that question as well in a poll. How many different types of cracks are there? And, you know, we kind of think to ourselves, well, really there's only one type of crack, which is a tooth that has a crack in it. But there are multiple extensions of that crack. So some of them extend very superficially, so an infraction. Some of them extend much deeper. Some of them are vertical root fractures, which are a completely separate entity. Lots of people are saying 4, some people are saying 5, and you're right, it depends actually which position paper you read. But they will talk about an enamel infraction. They will talk about a fractured cusp. They will talk about a cracked tooth. They will talk about a split tooth, or they will talk about a vertical root fracture. And really, it's the extension of that crack. And all you were very, very close, and between 4 and 5. It's the extension of that crack that's important. And you will find a lot of the AE stuff on their website. The link is there. And this webinar will be on demand. So you don't need to take photographs or notes of any of this kind of stuff. You'll get all this stuff quite easily afterwards. But it's quite good. I think in terms of assessing these, whether or not you need magnification, I would say yes, but actually I hate going to lectures where people say, oh God, if you don't have magnification, you can't see what you're doing and blah, blah. I mean, dentistry existed before magnification. And not only that, but looking at some of the photographs I've had from colleagues over the last few weeks in terms of the PPE that's being worn, I don't know where a microscope and loops are going to fit into it, because the visors and everything like that are going to be so substantial, and you're going to have an FFP3 mask on, and that creates a lot of probably condensation and everything. So I just think we should be a little bit practical and think about this stuff over the next few weeks, not to freak yourself out, but in terms of how dentistry might change, because our priority as clinicians will be our patients, of course, when we go back. And there's going to be a ton of work to do in a remedial sense, because the management of emergencies is very difficult at the moment. A lot of it is down to PPE, and I've spoken to people in Chalmers Dental Centre, and they're in a difficult position in terms of PPE and seeing patients who are either just presenting with swellings where the tooth potentially may be extracted. Patients who are in pain at the moment, that's a really difficult one, because it's not a life-threatening situation, but equally it's a massively uncomfortable and debilitating situation for a patient. But hopefully that will pass. But I don't know if it will pass to the degree that we will go completely back to normal very, very quickly. We will go back to normal. It might be a new normal, but it might take a little bit of time for that to happen. It's also important, I think, that you recognize when you're assessing a tooth what the crack means. And it means very, very different things in a tooth that is responsive to pulp testing versus a tooth that is root filled. This is a great paper. It was done, and I don't say this because I went to university there, but it was done by a registrar in Cork when I was there. And I think it's a good paper because it's very simple, and I like its description. It's talking about a cracked tooth syndrome. So you've got a patient who pathonomically will present with pain on biting, often something kind of hard within their diet. So they'll bite on something. And remember, today is about restorability and prognosis. It's about explanation and communication to your patient. Don't say to them, I know what it is, it's cracked tooth, because to them that means nothing. And unless you've got your AE diagram to show them, explain to them about the pathogenesis. So what's happening is the reason and we talked last week about history, if they're saying it's kind of sore when I bite, you want to direct that, not say to them, go on, tell me about that soreness when you bite. I mean, if I'm a non-dentist, I don't even know what that question means. Tell me about this. I would say, I don't know. Ask them, what is it? Anything when you bite it in particular that makes it a bit more painful? Is it sore when you bite? Is it sore when you open your teeth? Is it sore all the time? Is the tooth sensitive? And really what's happening in a cracked tooth, which has a cracked tooth syndrome, is that you've got two fragments of the tooth microscopically separating. You have fluid moving into internal tubules. And then on release, when those segments snap back shut together, that's when you're going to start to feel symptoms. So explain it in those simple terms to a patient. They will appreciate the explanation, and it will start to hone in your own consciousness and your own decision making. So you're saying, this is a cracked tooth syndrome, I can manage this. I'll get the restoration out and I'll assess the crack. You may or may not see anything. If you have some stainless steel orthodontic bands, great. Squash one of them on, leave it on for a couple of weeks, and in the vast majority of patients, it will help because you will mimic what a cast restoration or an indirect cuspal coverage restoration is doing. One of the things I would suggest when you do take a restoration out and you do look at a crack in terms of your own prognostication of those cases, look not only at where it runs to, because remember, you can only see with your eyes where it runs to, but look at how substantial that crack is. Is it stained? Can you get a probe into it? All of that is telling you, hang on a second, this has been there for a long time, it's relatively substantial. You don't need a flat plastic to separate two segments of tooth tissue to understand that something has been long-standing and may have an adverse impact on the prognosis of the tooth. Equally, with root-filled teeth, you need to ask yourself, what's the prognosis longer term for this? So if a tooth with a root filling comes in and you visualize a crack, did that happen before or has it happened subsequent to the root canal treatment? Or equally, if a tooth needs a root canal treatment, do you then, if you see a crack, is it substantial enough for you not to recommend that intervention? And that is really the gray area. One thing I will say is that Anil Kishan, who is a really good endodontist and academic in Canada, he has done an endodontic topics paper where they talked about the extension of cracks and how they move and how teeth flex. And just because there's a crack there doesn't necessarily mean that it will continue and progress to a tooth falling apart. Dentine buffers it in a particular way. So don't always assume that it's catastrophic, but equally, you do need some kind of red lines, you know, and red lines I will talk about in terms of root-filled teeth in a second. It's interesting, this paper, in terms of teeth that aren't root-filled, if you look at the paper on the bottom done by Sergio Cutler, they found that and lower molars are the teeth most often affected by these spontaneous cracks, and clinically they will often present as a minimally restored tooth, often with a shallow occlusal restoration, and the tooth will be necrotic, but there'll be no massive J-shaped radiolucency, and there's often no huge bony defect, perhaps a slight widening of the ligament space cervically from the crestal level as it extends down towards the apical region. But they found that if teeth were necrotic due to these cracks, that in the vast majority, in excess of 80% of cases, those teeth required extraction. And so that's interesting. That's not to say to you that if the tooth's necrotic, you can't do a root canal treatment on it because it's got a crack, but keep that in mind. Keep it in mind. You're wondering about how substantial that crack is. That's the key part of the prognostication here. It's not whether the crack is there. It's not, does it run into a canal? Does it run mesiodistally? In very, very simple human terms, it's, is this crack substantial enough to adversely affect the prognosis of my patient's tooth? And will they lose it even if I do treatment? And I mean in a short period of time, not in 10 years. That's, you know, probably a realistic time frame for any tooth that has a root canal treatment. And equally, the final thing you need to ask yourself in terms of cracked teeth, either non-root filled or root filled, what will it do to the bony site if I leave this unattended? If I treat this tooth, do root canal treatment, and then suddenly that tooth fails later, because that can make it very, very difficult. In terms of root-filled teeth, it's sometimes not easy. If you can see up on this image, I'm going to just turn on my pointer. Just bear with me for 1 second. You can see here, you've got a crack running down here. No evidence of any probing defect. It's more than an infraction, I have to say. And that tooth had become pulpitic, and it needed endodontic treatment, which was carried out and was uneventful. But the decision we were trying to make was, how do you restore it afterwards with cuspal coverage? Do you, and this again is all linked to my understanding of prognosis and my attempt to say, am I giving this tooth the best chance? And you've got plenty of dentine remaining. An onlay might be a satisfactory restoration here, but we felt that with the extension of the crack along the full coronal tooth structure, that a full coverage restoration might be better. Now, it's hypocritical or counterintuitive, call it whatever you want, the crack is probably disappearing subgingivally. And I never ever was a person who believed that you should follow a crack and drill it out, because you can't see a lot of them. But when you look at a situation like this, I felt a full coverage restoration was probably more appropriate, because it would give me, in my mind, probably more than anywhere else, that added amount of protection in terms of the custal coverage that I put on. And that's it, waxed up, full gold crown put on the tooth afterwards. The survival of these teeth is a key part of our prognostication after. And there are lots of ways to look at this. And again, don't take loads of the evidence and try and squash it into your mind. Again, I go back to Dawood and Patel: endodontic, periodontic, restorative, and the overall context of the situation. So the bigger picture. I look at teeth that have cracks visible in them. You can become obsessed with, is it in a canal? Is it mesiodistally? Is it just down one cusp? Do I drill it out? Look at the crack, examine it, and assess it in terms of its extent. You can develop your own red line for that. Look at it in terms of the overall context of the patient. And really importantly, and this comes up from Tan's study that you're looking at here, is there any associated probing defect? Because they found that there were a few prognostic factors that were important. But one of the things that came up over and over in the literature was, if you have a concomitant probing defect, that tooth is essentially for the bin. And you're wasting your time, I think, trying to maintain that tooth. Now, if the tooth is not root filled and you find a probing defect, you also need to put your prognosis hat on and try and say to yourself, could this be an endodontic periodontal lesion? Now, if it's truly endo-perio and you think this tooth is not cracked and I've visualized it internally and I see no evidence of a crack, versus the situation where you open a tooth up, you have a probing defect, and then you find a crack, for me, that's pathognomic. It should probably go. But if you can't see any visible signs of it, there's nothing wrong with instrumenting that tooth, dressing it with calcium hydroxide. The recommendation is to wait for 2 weeks. I would wait for 4 weeks personally. Wait for 4 weeks, bring the patient back. If it's true endoperio, that probing defect should resolve, because the reason for the probing defect is the endodontic pathosis extending into the periodontium. If it's perio-endo, you treat the tooth periodontally, and the endodontic prognosis of the tooth should be unaffected, in inverted commas, until such time as the periodontal defect progresses to a level at which the neurovascular bundle apically may be affected either by the disease or by your instrumentation to clean the root surface. But that is really, really important. Don't rush to say there's a probing defect, tooth needs to come out. You've got to establish why that probing defect is there and what's the etiology of the probing defect. Another thing that comes up quite regularly is the position of the tooth in the arch. Is it a terminal molar? Because if you've got that tooth there and it's got a probing defect and it's root filled, there's no hope for that tooth. And then if you think as well about what I was saying earlier, whether or not the bony site will be affected, because if that tooth fractures catastrophically or you leave it for long enough, you'll have no bone left either to consider putting a replacement in there. And then that's going to make it very, very difficult in terms of prognostication, in terms of explanation to your patient, and it may limit them in terms of their replacement options. And I think that is often one of the situations we face when we look at teeth and with posts in them. And these are 3 different examples. And one of the things I would like you to look at here is I'd like you to look at the nature of the restoration that's up on top, okay? And which tooth would be the most difficult tooth to restore after, or to put it another way, which of the teeth is the most unrestorable of the 3? And looking at these, all of them are going to be very heavily restored, okay? All of them have got post crowns on them. All of them are going to have relatively limited amounts of tooth tissue underneath them. But which of these looks to be the most unrestorable? And I think some of your, lots of different opinions here, and you know it's difficult because you look at a 2-dimensional image. A lot of people are leaning towards number 3. And I think one of the things to look at, in terms of, first of all, the difficulty of post removal here, probably the second tooth is the one with the most difficult post removal. okay? And that's how it was borne out in clinical practice. And that's because of the cervical bubble of metal work that's here. That's really well adapted cervically, and they can be a killer to take out of a tooth because you've got nowhere essentially where your post is just going to move gently so that it will actually dislodge out of the tooth. And that's really, really difficult. And sometimes that involves having to trim a little bit of cervical dentine with a very narrow composite polishing burr, or maybe using a very fine ultrasonic tip. But one of the things in terms of restorability or unrestorability that worries me most here is the cement lute around the canine tooth here. It doesn't seem to be as obvious around either of the other teeth, and that when we look at it, you've got probably a satisfactory amount of tooth tissue coronally on the lower incisor on the far right hand side, and the tooth in the middle is a difficult one, and probably that will be my second choice because you have got a deficient margin at the distal. But looking at these, it's very, very difficult to make any kind of a decision, and our opinion is completely divided. We've got a 40-40 and 20 division, 3-2-1 there. You would have to dismantle what we've got here. You'd have to take it apart completely, see what you've got underneath. But I think the canine tooth in the first image is certainly a worry because of that cement lute that's underneath it. And sometimes those posts are the one, and that was what was borne out in clinical practice. That post came out very, very easily because there's nothing, there's no ferrule remaining there. And if there's no ferrule remaining there, it's a fence post in the ground. You rock it backwards and forwards and it will just pop out of the tooth quite readily. And then I think sometimes we're faced, and this Style Italiana website's really good. There's a guy, Marto Martignoni, who is an endodontist in Rome. He does a lot of stuff for Dentsply, and his dad was a prosthodontist, and he puts a lot of images on this, and they look really good. And I looked at this because I was looking for something in relation to marginal elevation, just in terms of the photographs, because I wonder about marginal elevation, whether or not, are we making something restorable that is in essence unrestorable? But equally, if we look at all the other factors, and if just the restorative prognosis is adversely affected by the position of the margin, then what's wrong with that? When you get into the realm of surgical crown lengthening and multiple interventions and waiting for 20 weeks, according to Mike Wise, for the outcome of the surgical crown lengthening to be known and before you can put your final restoration on, I wonder how practical it is in a practice setting. And if you've got a tooth that requires root canal retreatment, surgical crown lengthening, and indirect restoration, and a patient is investing an enormous amount of money in order to maintain a tooth, you potentially wonder whether or not it's worth just removing that tooth and replacing it with something else. But characteristically, these are the type of teeth that you see. And this is where it does, I think, have a role. You see a tooth which is relatively sound everywhere else. Patient's got a minimally or moderately restored dentition, but you've got just that one area where you've got a deeper margin. Crown lengthening, of course, has a role to play. For one individual tooth, it's quite a complex intervention, and maybe too complex an intervention to do in the anterior region of the mouth. But potentially marginal elevation can play a role here. And when I look at the evidence on it, I still find it to be kind of quite confusing, because they will talk about not using an open sandwich, using standard GIC, but potentially using a resin modified like your GIC might be more acceptable, or using something like a flowable composite or an SDR. But you still face the very same difficulties, because if you put a matrix band on, and if you think you need to do a marginal elevation procedure, you still have to isolate the tooth. You still have to make sure that you're not getting saliva. You still have to make sure you're not getting bleeding in there. And that's sometimes where we face our challenge. And when I talked about the kind of crime scene component of restorability, one of the really useful situations for me in a patient who just says, look, I'm really, really keen to try and keep this tooth. I will say to them, I will dismantle it, I will assess restorability, and I will say this before I start it. But one of the acid tests for me is, can I get a matrix band on this tooth? And sometimes it's not for the want of trying. I will try and try and try multiple different systems, see whether or not I can get it on. If you can't get a matrix band on a tooth in order to put a flowable type restoration, like an SDR or a flowable, a GIC, you're never going to get a direct final core in there. And you'll end up either with an overhang that you'll spend all day trying to adjust at the end, or you won't be able to adjust it. And as human beings and as clinicians, we look at those restorations after and we just say, I knew it and I'm disappointed. So for me, that's again a useful rule to apply to say to a patient where they're struggling to understand the relevance of a ferrule or the relevance of a margin being in a certain position. Simplify it down and say, listen, if I can't get a predictable matrix band on and look at it down my loops and confirm that it all looks well adapted and intact, then I'm not going to be happy. And one of the things I think that you have to do in the pre-treatment stage, and remember, there's no contraindication if you assess restorability and you confirm, I think this tooth is restorable and I think the prognosis of the tooth is good or satisfactory, if you want to avoid using good or bad type language, then what you can put a direct restoration in. You know, a lot of practices are almost amalgam free, if not amalgam free. And if you're going to put a composite in, you could put your definitive composite core in and you could subsequently put a little small access through it and maintain as much of that composite as you can and put a little access cavity restoration in it afterwards, particularly if you're putting an indirect cuspal coverage restoration over it. But I do think the adaptation of that needs to be good. If you're putting the final restoration in before you do the treatment, it's the same as putting the final restoration in after you're doing the treatment. The use of PTFE tape with the paludent is quite helpful, both kind of higher up onto the contact area, but also right down there cervically. And one of the difficult things with putting any restoration in is when you put the matrix band on and you put the ring on and you're looking and maybe there's a wedge in there and you're thinking, why is there still that tiny little space? And you know it's well adapted, but it's just the contour of the tooth. And so getting a little bit of PTFE and squashing it into the contact area and don't use a standard dental probe, but maybe a periodontal probe to adapt it or to kind of push it into the contact area, because you don't want something too sharp. It's just awkward in terms of it will get stuck in the PTFE and pull it back out. But just gently, or even with a flat plastic, push it in underneath that contact area, and it gives you a really nice adaptation of the band in there. And I think that's important, because I think that restoration really, be it the final one or be it not, is important. Looking at this tooth, I think, and this goes back to the crime scene part again, it's what we do during our assessment of it that tells us the answer. So we take out a restoration, we can't get a matrix band on. Useful rule to say to the patient, look, I can't get a band on it, so I'm not happy. Another useful rule is if you can't get rubber dam on, there's a fair chance that a tooth is possibly unrestorable. Now, this is an interesting one, because I've asked this question many times before, and this divides opinion. Because I think when I look at this, if someone showed me this image, I would say this tooth's unrestorable. But yet, if it presented to me, I would probably think, oh, I don't know, I'm not so sure. You know, is there enough dentin? It's a funny angle on the photograph, but you don't have to isolate that tooth in order to put rubber dam on. You could put the clamp on an adjacent tooth. You could put a premolar clamp or a butterfly clamp on an adjacent tooth, preferably premolar, because the wings of the butterfly may encroach over it. But you don't have to be able to isolate that tooth. You can always use a split dam technique once you can adapt the rubber dam correctly and put some liquid dam or some Oroseal around it to avoid any leakage either in or out. You can certainly put rubber dam on an area like this. And then that will allow you to do your treatment. I would put rubber dam on a case like this right from the outset before I ever took the crown off, because as I said before, it allows me to get right to an end point, or up at least until making a temporary crown point, without taking the rubber dam off. And so it just simplifies my overall treatment procedure. In terms of adapting a restoration afterwards, someone has asked a question which is actually very relevant and very practical, not specifically for this tooth, but just in general to do with matrix bands. Even if you put a split dam on, do you not still have the issue of getting a matrix band on? And I totally agree with that. And that's why if you're looking at a tooth and it is really heavily restored and you are planning at some point to remove all of the restoration, you need to do that at the very outset. I wouldn't, in a situation like that, I wouldn't wait and access through it and then say, oh, well, I'll take it out after and I'll put a new composite, for example, in to replace an amalgam. Because the problem there is at the very end, you'll realize I can't get a matrix band on this. And what do we say to our patients? Do we say, well, it's okay, I'll give you the root treatment for free, but your tooth needs to come out? That's not going to wash with them. And you'll have spent so much time doing it. I think one of the advantages of split dam in a practical sense is that you can isolate adjacent teeth. And sometimes, let's say, for example, I'm doing a lower first molar, I may put a clamp on the 7 and I will put a premolar clamp the wrong way around on the 5. So I'll face the bow of it mesially, and that will stabilize the rubber dam, and it will give me a completely free first molar tooth around which I can put my auto matrix, for example, because sometimes I find, and this is dependent again on what clamp you use, you want to make sure that you've got that space, not just for the matrix band to fit the tooth, but for the contour of it to be correct and unaffected by the wings of the clamp or the position of the clamp. So that's important. And sometimes that means playing around with the rubber dam clamp. So it means that you maybe put a premolar clamp on a molar tooth and you put a deciduous premolar clamp on a premolar tooth, because you do want enough space upon which you can put your matrix band. And then again, this is another example of it's what we do or it's what we don't do. And this is a case where I treated this, the root canal treatment part was done, and I was doing, this is many years ago, I was working in Ireland at the time. And I look at this now and I just think it would have made way more sense to just take that restoration out. It's got an amalgam, a GIC, and some kind of IRM. And for me, there's a question mark over the restorability. I was working with a prosthodontist at the time and they were comfortable to restore it. So there's a happy ending. But looking at that now, again, it's what we don't do at that crime scene. It should be dismantled, because I'm looking at it and I'm thinking that tooth needs a post. And why isn't there a post space prepared in the palatal root canal to facilitate restoration placement, to facilitate the person who's going to take over the case and put the indirect restoration on? How can I prognosticate this case? It's looking at it in a kind of through a telescope, small-minded, I'll just do the root canal treatment. And the root filling, there are 4 canals. The prognosis of the tooth endodontically is good. But what's the prognosis of the tooth restoratively? And this is an important tooth. There's limited bone there. You've got a sinus that's pneumatized. You've got a difficult situation in terms of replacement. So it's interesting. It's back to that crime scene. Why not just clean it up there and take a look then? Because I think sometimes actually, and you can look at a case like this, sometimes it's the adaptation of those restorations that's most difficult. And this was a case that I had treated. I dismantled these teeth beforehand and restored them permanently, because I felt, okay, I had rubber dam on my 7. I used sectional matrix systems. I tried to adapt the contour as best I can. And I was confident then afterwards doing the root canal treatments that I was going to get a result in terms of the restoration as well, because I was able to put definitive restorations in, as opposed to saying, oh, well, I'll access what's there already. The adaptation of those restorations is actually quite difficult, but of course has an enormous impact on the prognosis. And again, sometimes it's what we do that causes the tooth to be unrestorable. So this is a case, and I've shown this before at a variety of study clubs, but the tooth was accessed and the patient, it's a long story, but the patient was absolutely adamant that they wanted to maintain the tooth. And there was a system whereby, I was working in Australia at the time, whereby they would sign off and agree that this was the last treatment they were going to have. If it fails, that's it, the tooth comes out. And the patient was offered the chance to have an implant, but turned it down. And when we look at a situation like this, for me, I think that tooth is certainly borderline unrestorable, would be a very fair way of saying it, because you've got a very large perforation. And I've popped up a poll to ask you, what do you think are the factors that affect the outcome of a perforation? So we look at it, and I always say we freak out far too much when we look at perforations and when we look at broken instruments, because we look at them, and I don't know why it is, but we're all terrified of them, me included. And it happens and we kind of think, oh my God, that's terrible. Looking at a tooth like this is one extreme, looking at it and saying it can be repaired. Anything can be repaired. And this is a very relevant thing to do with prognosis. Anything can be repaired, but that's not necessarily saying that anything will be successful or anything will survive or anything will give you an outcome whereby you'll be happy and your patient will be happy. And interestingly, the majority of you are saying site, which is definitely one of the factors. The size of the perforation is important as well, but one of the most important things, and this is one of the things we always miss, and this is one of the things that I think you guys are in a hugely advantageous position on, is the time it's been there. Because the longer it's been there, theoretically, the more infected it will be. And the more infected it will be, the more difficult it is to try to disinfect it because you're trying to run some hypo over it, but not into it. So if this does happen to you, not just during a restorability assessment, but during treatment, assess the restorability there and then. You would be the best place to do it and just cover it. Cover it with something like a GIC, even if it means you cover the orifices and you're in a position where you think, I can't go back in there because I can't do it. If you're going to refer it onwards, cover it over with something. And failing that, maybe run a little bit of calcium hydroxide paste over it. It's going to be uncomfortable for the patient afterwards because calcium hydroxide's got a really high pH and it creates a superficial layer of necrosis, but it's antibacterial. So do something like that and try and address it at that stage, and that will help an awful lot. The other thing I would say is, and we're kind of coming close, I suppose, to an end point now because we're looking at the restoration of the tooth, and I'm not going to talk too much about restoration because we'll talk about it in the later webinars, but you always, and think back to that tooth, the upper left molar I showed you earlier, you always want to look at how much dentine you've got left in the prepared tooth, not the tooth with the restoration in. So if you look at the amalgam restoration in the premolar up on top, and you look on the image on the left of that, there's a post in there, and you think, did that tooth need a post? And you can argue one way or the other. Every post doesn't have to be a certain length. It should ideally be the same length as the crown, but it's a short little clinical crown, so it only needs to be a few millimeters long. You know, it doesn't have to be extending right down into the root. This root had a kind of a curvature mid-root. And so extending it too far down, you were going to encroach onto the danger or furcation area. But you look at this and you think, look at what the prepared tooth looks like afterwards. Equally, don't apply these blanket rules of, oh, Sorensen and Martinoff said if it's an MO, you need to put a crown or an indirect restoration on. Look at how much residual tooth tissue you have. So if you look at this situation, look at where this occlusal restoration is encroaching to. This is it preoperatively. It's so, so close cervically, okay? So you have got that kind of weakened piece of dentine and enamel here. So if you look at that and you apply common sense to this and you say, okay, this tooth is weak here, I'm going to put cuspal coverage on it, but don't necessarily prep it for a crown because you're going to take away this area and you will join the margin of your crown to your internal access cavity restorative material. So in a situation like that, although it's just an occlusal, you don't apply a blanket rule. And what you do is you put something like an onlay on it. You can see with the dye up on top, the section dye with the blue material on it, you can see the extent of the occlusal access and you can see how close it is to that mesial margin. So it's prepared for an onlay. The onlay goes on, you achieve the goal of cuspal coverage, but you don't take away dentine unnecessarily. All of that helps to improve the prognosis. It's the same principle when I said earlier, if you look at a tooth and it's got a deep periodontal defect, but it's responsive to pulp testing, and it doesn't give you an indication that it's endodontically involved, doing an endodontic treatment on that tooth reduces the prognosis, because doing an endodontic treatment on any tooth that doesn't need it is not an intervention that is going to improve the lifespan of that tooth. And in terms of the lifespan, you need to consider what it is that you're trying to achieve. Is it survival? Is it success? How do you communicate it to your patient? So if a patient asks you, will my tooth last? Sailor-Abbey and Rothstein gave really high figures in terms of survival of teeth, up into the 90% range. Tickle did his paper in 2008 and talked about it in terms of NHS-funded endodontic treatment. They looked at 174 teeth. They had a crude failure rate not being different for suboptimal root fillings, optimal root fillings, or unreadable radiographs. So that would worry you slightly. But they did find that survival rates were very, very high. And 67 of the teeth in that study had a crown on them and none of them failed. So certainly, although I wouldn't say put a crown on everything, that clearly can have an impact in terms of the survival of the tooth. Now, as clinicians, we are focused on success, and success is clinical, no signs and symptoms, radiographic, return to the normal architecture. But there is this concept as well of functionality, and this is how you prognosticate. You communicate with your patient and you say, what is it that you are expecting from this treatment? No patient will say, I want a functional tooth. But lots of patients say to us lots of the time, I just want to keep my tooth. So you need to explain it to the patient in those terms. And this is the paper from 1957 from Ernstein. And it talks about the idea that the public is cognizant of the advantages of scientific diagnosis and treatment, but it takes these more and more for granted. If a patient goes to you to have endodontic treatment done, of course they assume that you know what you're doing in terms of endodontic treatment. The difficult questions we face are, can we give the patient some kind of guidance in terms of whether or not this tooth will last for them, whether or not the treatment will work? And we need to understand ourselves what it is that those things mean. So explain to them that the survival of the tooth is very, very high, almost guaranteed. It's up in the 90% range, but that we are aiming for success, that we're aiming for clinical and radiographic success, and explain to the patient in terms of what you're going to do to try to guarantee that. Talk to them about endodontic, periodontal, and restorative aspects of the treatment that you're going to carry out, and simplify that down for them so that your algorithm will say, if you've got a satisfactory endoprognosis, I can do it. If you've got a satisfactory periodontal prognosis, I can do it. If restoratively, I can get a restoration on it. You can get a restoration on it. That's a personal thing. Then you can do it, and look at it in the context of that patient. Are they a patient who's willing to accept some risk? Are they a patient who is very, very demanding in terms of their outcome? And don't look at that as a negative. That communication, and then being able to say that to you during the consent process, that is consent as such. And that's something we should value and not become frustrated with. So my rule of 3 for this would be, in terms of restorability, in terms of prognosis, it's about what we find when we get in there. Okay, you have no control over that. It's about what we do when we open a tooth up, when we take a restoration out, or maybe when we're doing treatment and something doesn't go to plan, as it did with the perforation case earlier. And most importantly, the prognosis and the restorability and all of those factors that influence the outcome, all of that needs to be communicated to the patient. And we need to be able to communicate that in such a way that the patient understands it, because they appreciate that we know what we're doing and they understand that we know what we're doing, but we have to explain to them why it is that we're coming to the decisions that we're coming to. Okay. Final thing I will say, this came to me this morning when I was looking after my kids. I'm sure some of you are familiar with the Go Jetters, and if you're not, it's probably worth a watch. But something came up this morning. It's very educational, so I'm clutching at straws and finding education for my kids on TV now, just to pass the time. But there was a thing on about Amelia Earhart this morning, and one of her famous quotes was, "The best way to do it is to do it." And I always say that this is so relevant to dentistry. In terms of restorability, the best way to assess restorability is to get the restoration out. Look at the tooth and see what you've got left. The best way to communicate it to a patient is to communicate exactly what you found to the patient. So if you look at a radiograph, don't pick some stuff out of it and say, I think this is probably what's most relevant. Develop your system. Look at Dawood and Patel's paper. I'm happy to send on the link for that as well. And I can get Magda to send it on to you guys, or send on a PDF to you. But look at what they talked about: the structural integrity of the tooth, the restorative or the endodontic prognosis and the periodontal prognosis. But you have to do it. And as I say, the best way to do it is just to do it. Okay. So thank you for joining. We will meet again next Thursday. Sorry, after all my talk last week about potentially changing the day, it was me was the one who had to do it. So we'll meet next Thursday. We're going to be moving on to the more kind of endodontic technique aspects of it. But what I'm going to do is I'm going to make it case relevant. So I'm going to show you specific cases, specific mishaps, photographs of cases, because I appreciate a lot of you guys are doing this all the time. And, you know, to paraphrase Amelia Earhart, the most effective way to do it is to do it. I don't want it to be just about, you know, the principles and the academia behind it. I want to give you some tools that you can take away from this series and say, I remember actually what he said, and this is relevant to me. So I hope that in terms of diagnosis, you took away a few things, you know, about the simplicity of the questions we ask our patient and how to guide them without interrupting them after 12 seconds. And I hope that from today, you can take something away and say, actually, maybe we oversimplify our assessment of prognosis. And then when it comes to it, because it's a subjective decision, we make it very, very complex. When in reality, if you apply a few little rules across it, it can be a little bit more simple to number one, make the decision, but more importantly, communicate that to the patient. So yeah, I look forward to catching up again next week. This is on demand as well, so it'll go back up and Magda will send you the CPD certs. And enjoy the week, guys, and hopefully we'll all be back to normal practice soon. Okay, take care. Bye-bye.